Thank you very much for the opportunity and the very nice introduction. It's kind of a nice break for me to be here today to speak about cannabis. Some of you may recognize me as someone who talks a lot about opioids and supervised consumption and the overdose epidemic that we're currently experiencing acutely in Calgary and Edmonton and across the province. And so I actually started my drug policy research and world as a cannabis scholar, and that was back in 2008 at the University of Toronto, and at the time I had no idea how relevant the stuff that I was working on, which no one really talked about, and it wasn't really, one of those hot areas, has become quite relevant in the past few years, and so it's exciting to share some of my knowledge on this topic with you today. So today I'm going to focus primarily on just a brief overview of the cannabis-related harms. I know we've had some discussion of that today, and I'll give you some background on historical approaches that we've typically taken to prevent harm related to cannabis, and then I'll get into some promising prevention strategies moving forward. So it's really important to emphasize that most people who use cannabis do so without experiencing any significant harms. And typically cannabis use is concentrated amongst younger people, but more often than not, and definitely for the majority of people, cannabis use tends to taper off as people develop new social roles and take on new responsibilities. And so similar to how some people may engage with alcohol in a riskier way when they're younger, typically you kind of age out of a lot of those behaviors. But what we do know is that for people who initiate cannabis use in early adolescence, so like the 10 to 15 kind of area, they're at a greater likelihood of developing problematic cannabis use, of developing dependence or cannabis use disorder, and of having longer cannabis use trajectories. And so when we talk about preventing harm, we often focus quite a bit of attention on that early adolescent population. So there's been a lot of questions today about, is there evidence to support X, or what's the evidence about whether cannabis increases Y? And I would just point you to this report, which just came out, I think it was last month, or I don't know, everything blurs together, a couple months ago. It's from the National Academies of Medicine in the United States, and they reviewed 10,000 studies on the state of cannabis and what we know about its impacts on health and its therapeutic benefits. And when it comes to understanding sort of population health impacts or long-term health impacts, they did conclude that we don't really have a lot of conclusive evidence. And so, yeah, and that's, I know, been a theme today. But they have ranked, and they asked dozens of questions. They ranked the evidence, in terms of strength. And the summary part of that report is really easy to understand and very useful. So if you have specific questions about harms or benefits, please go and check out this report because it's really well done, and I think it clears the air, no pun intended, like on a lot of these problems, or a lot of the misinformation that circulates about cannabis. So what did that report tell us about harm that you might experience if you're using cannabis recreationally or leisurely or for other reasons? There is substantial evidence to support a statistical association between the development of schizophrenia and other psychotic disorders. But what we know is that it likely has to do with, or is mostly a risk for people that have a genetic or biological liability. So it's not necessarily a causal relationship that cannabis causes everyone to develop schizophrenia, but that it could exacerbate underlying conditions. We also do know that there's substantial evidence to support that acute intoxication from cannabis does increase the risk of a motor vehicle collision. It does increase the risk of low birth weight for offspring if you're using it while you're pregnant. And with long-term use comes some respiratory symptoms, including chronic bronchitis, that could be problematic. And problematic patterns of use and cannabis use disorder are much more likely to happen when somebody initiates early on or if they use heavily over the longer term. And it's worth noting that males and those who use tobacco are particularly at risk for those problems. So how have we typically tried to limit harm from cannabis in Canada or in North America? I have the word here conventional approaches, but in reality, these are ineffective approaches that we've been using, and I'll tell you why in a moment. So the first main approach that we've been taking for a very long time, since 1923 in fact, has been trying to prevent harm from cannabis through criminal enforcement of abstinence from use. In Canada currently, the max penalty for possession of under 30 grams of cannabis is a $1,000 fine or 6 months in jail. And the majority of people who are arrested for a drug offense in Canada are arrested for cannabis possession. And it's worth noting, because sometimes there's some misinformation about this, that in 55% of all cases where a charge for cannabis possession is laid, that is the only charge being laid in that incident, okay? Because sometimes we hear like, oh, well, the police never charge anyone for cannabis possession, and if they do, it's only because they did a bunch of other more serious crimes and, they tack that charge on. Well, the data from Stats Can show otherwise. So the hypothesis with, the attempts of criminalizing cannabis use and possession is that if we have criminal penalties, they will send a message to youth that deters them from using cannabis. And, typically would think that more severe penalties are expected to have even stronger deterrent effects. Unfortunately, the legal impact hypothesis is not correct. And so some people have mentioned, we know that we should legalize because Canada has one of the highest rates of youth cannabis use in the world, and that's true. But why is that, right? Why do criminal penalties not work? Or what's the underlying evidence to support that? And so this graph here is from the European Monitoring Commission on Drugs. And they looked at a bunch of different policy changes that have happened in Europe around cannabis over the past 2 decades. And so they've mapped these policy changes, and this graph you're looking at essentially shows you changes in youth cannabis use prevalence over time. And the green side is pre-legal change for a certain country, and the blue side is post-legal change. And if the bar of use, that's the prevalence of use, is orange, it means that the penalty increased for that country in the blue area. And if the bar is blue, it means that the penalty was decreased in the blue area. And so this is kind of a messy graph, but what it shows you is that there is no clear or simple association between legal changes in prevalence of cannabis use, legal changes in the law, so either increasing penalties or decreasing criminal penalties, and the prevalence of cannabis use, okay? So in some cases, like United Kingdom, we can see that they decreased penalties and use went down. But in other cases, like Finland, we can see that they decreased penalties and use went up. And so what this suggests is that the criminal law actually doesn't have a lot of bearing in terms of whether people decide to use cannabis or not. And so, okay, those changes were mostly changing penalties for criminal penalties and some decriminalization. But what do we know about legalization? Because that's removing criminal penalties entirely. And actually legally regulating and making it freely available to certain people of a certain age. Well, I'm not going to get into too much detail because I think Dr. Kilmer did a really great job explaining the data or the state of the evidence or lack of evidence on this. But so far, indications suggest that youth rates, and particularly for teens, have remained stable in Colorado and Washington, where they've had very large population surveys conducted. So beyond being likely ineffective at deterring use, and maybe in the discussion we can talk about some of the principles of deterrence and why criminal penalties may not deter use in these instances, or for drug use in particular. But beyond that ineffectiveness, we know that when we criminalize something, we spend a lot of money enforcing that law. And a lot of that money goes to putting people in jail, goes to courts, goes to paying lawyers, things like that. And what that means is that money is not available to invest in other approaches, and other approaches that actually have evidence of effectiveness. And so in Canada, we spend the vast majority of our resources on enforcement for cannabis and for other drugs. And removing criminal penalties and taking cannabis out of the criminal system, I'm hopeful will have and generating taxation revenue, will have the added benefit of being able to invest more in prevention and harm reduction. Additionally, we know that criminalization has a number of iatrogenic impacts, so unintended negative consequences. And I'm not going to go into too much detail, but we know that there's a lot of differential enforcement across the country. Not everyone has the same risk of being arrested for cannabis possession. A criminal record stays with you for your entire life unless you get a record suspension, and it can have significant consequences on your productivity and your ability to travel. It also fuels clandestine production, contaminated and unsafe supply. And as we've seen, it prohibits effective population surveillance and screening for high-risk cannabis use. So what's the other way that we try to reduce cannabis harm or cannabis-related harm currently? Typically, we invest a lot of resources in universal prevention through individual level risk reduction. And so this is things like public education campaigns or school-based programs that are focused on promoting abstinence from cannabis and other drugs. And a common one that we're very familiar with is the DARE program. Another one is the Health Canada ads that we had a couple years ago that were talking, like that Juicy or whatever, if you saw that ad where they're using all these weird names I've never heard reference for cannabis, and I don't know where they came from. So that's a common approach that we take. So what do we know about the effectiveness of mass media education campaigns targeting youth and school-based programs that focus on individual level risk reduction through social influence or through trying to build individual skills and their capacities to resist peer pressure and also impart knowledge about the risks of drugs? Well, I'm not going to go through these tables, but if you're interested, I'm going to share these slides so you'll be able to look at the references. But basically, we know that these approaches don't work. There's very little evidence to support the public education campaigns. They make us feel good. We think like we're doing something. They're pretty easy to pull off because we just hire a consultant to make a flashy ad. And it catches attention, but they actually don't really do much to shape or change behavior. Same thing goes for when we're just trying to address individual level deficits in children and youth. So if we're trying to give them knowledge or give them skills, typically those approaches are ineffective, and even when they're executed really well, they have just modest impact in terms of behavior change. And so why is that? Like, what are the issues with these approaches? Well, there's three main problems. One, a lot of times we dream up these great programs in our research labs and our different settings, and then we don't actually implement them how we said we would. And so there's implementation failure. And so something gets rolled out, but it's not really what we had planned, and it's not consistent with our theory of change in terms of reducing drug use amongst youth. Another issue is an overemphasis on abstinence as the outcome of interest. Abstinence is a really high goal, and just like with sex education, it's probably unrealistic to think that if we ask people to be abstinent from cannabis use, which is a risk behavior, just like early, teen sex, it's probably unrealistic to think that people will just abstain because we ask them to, right? And so we do need to give people tools to stay safe, even if they choose to engage in risk behaviors. The third piece of this is we really overemphasize the individual level and this kind of like didactic or even interactive trying to change people. We really need to change environments and change the factors around people if we want to encourage healthy decisions. And that's a key tenet of public health and something that we can really build on when we're improving prevention programs. So just to sum up, what we know is DARE has been shown to be conclusively to be ineffective, and in some cases actually has unintended negative consequences. Yet in Alberta and elsewhere, we continue to invest in this program. The science is clear on this. We need to stop putting money into it. Community-based settings, what do we know? Like I said, out-of-school youth, brief interventions, there are some evidence to support these approaches. There's no evidence of effectiveness for mass media campaigns. And in schools, we know that passive knowledge-based approaches don't really work. Individual skills-based approaches can work, but only with modest impacts, and only if they're interactive, include multiple sessions, and are not delivered by police. Comprehensive approaches are promising. So what are these promising approaches? And I think we have a huge opportunity, really, we do, to overhaul universal prevention to not only improve health related to cannabis, but to improve health related to a number of risk behaviors that youth every day engage in and that we can do something to address. So let's take that opportunity and see what we could potentially do. So from a public health perspective, our focus tends to always be on just understanding there's a spectrum of psychoactive substance use and that a lot of people engage in leisure activities with psychoactive substances. I had a couple glasses of wine last night with some of my colleagues here. And if it's casual and non-problematic or if there's benefit to it, like public health doesn't worry about that so much, right? Go ahead, do it, right? It's not causing harm. It's not causing a population burden. So like why? Why focus resources on that? What we like to focus on is problematic use and chronic dependence. So we want to prevent those things from happening, and if they do happen, we want to try and address them. And so practically what that means is that when in the cannabis world, we're trying to prevent early initiation because we know it leads to a lot of negative health outcomes. And we're also trying to help those that do decide to initiate in adolescence to use in a safer way. So how do we do that? Well, first we have to understand that substance use is a social phenomenon. It is not just the product of individual deficits in knowledge or skills, okay? Substance use is influenced by a number of different risk and protective factors that occur at different levels. And this is called the socio-ecological model. And what it basically tells us is that if we want to shape behavior, we need to typically influence at more than one level on this model, okay? So it's not enough to just focus on an individual and give them knowledge. We also need to shape peer norms in the interpersonal network, or we need to shape the school environment to encourage healthier choices, that kind of thing. So effective prevention programs are those that target multiple risk and protective factors, intervene at more than one level, and often have a broader focus. In fact, what we know is the best evidence supporting prevention programs for drug use don't actually talk about drugs very much, okay? There's an underlying core set of risk and protective factors that influence young people's drug use, but it also influences being violent, bullying, doing a bunch of other risk behaviors. Those things all come from the same place. And so if we can address some of those core underlying things, then we can actually have positive benefits beyond just reducing cannabis or reducing initiation into opioids or something like that. So when it comes to youth, there's two main domains of social influence that it's really important to try and target when we're doing prevention. The first is peer networks. As any parent will tell you, especially of teens or early adolescents, peers are very influential in children's lives. And so if we're trying to understand substance use, and cannabis use, we need to see it as a situated product, not so much of peer pressure, but of active lifestyle decisions in keeping with group norms within social contexts of constraint and opportunity. Okay, so if we want to influence drug use, we need to shape the peer culture, we need to shift it in a positive way, away from riskier behaviors. Another important domain of social influence is family. And so structure and quality of family life predicts early initiation into cannabis use, and it's a risk factor for other risk behaviors. And that's been operationalized in the literature in a variety of different ways, but what seems to be really particularly important is a lack of parental monitoring often predicts early adolescent use and other risk behaviors, which doesn't come as any surprise. So how can we affect these domains of social influence to encourage healthier decision-making for youth and young adults? Well, there's actually several examples of successful prevention interventions that have done this and have intervened either amongst peer networks, amongst family, parent relationships, or both. And one is the Gatehouse Project in Australia. Another one is called Strengthening Families from the US. And I won't talk about those, but I will talk about the Icelandic model because I think it's been getting a bit of attention lately, and it's really interesting. What Iceland has done is they basically implemented a variety of interventions. They took a whole of society approach, and they were aiming to, one, strengthen parent and child attachment, and two, engage adolescents in their family life and also in alternative leisure activities. And so they did things like they made parent-school community or councils mandatory and said that parents had to participate in those so that they would know what was going on at the school. They had parents sign pledges saying that I won't let my early adolescents out past 10 o'clock, and I'm pledging to do that. And so that pledge was not so much coercive on the parent, but it had the effect of having a bunch of parents agree to that term. And so kids couldn't go and undermine their parents by saying, well, so-and-so is getting out at past 10, so why can't I? They also invested a ton of money in providing alternative leisure activities for youth. So they gave subsidies for getting youth involved in sports. They set up all kinds of alternative recreational programs for youth to engage in. And so they gave youth, things to do besides drinking and using drugs like in the evenings and on the weekends. And so how did that turn out for them? Well, they implemented this program in 1997, and they used data that showed that they had some of the highest rates of alcohol and hash use and cigarette smoking amongst youth in Europe, like compared to the rest of Europe. And they implemented all these different interventions, and over time, they were able to significantly improve a number of outcomes for youth. So the percentage of 15 to 16-year-olds who reported often or almost always spending time with their parents on weekdays doubled from 23% to 46% with these interventions. And the percent who participated in organized sports at least 4 times per week increased from 24% to 42%. And so a lot of these things that they were targeting did actually have positive changes. And so what was the impact on substance use? Well, as this graph shows, basically they were able to cut in half the rates of becoming drunk in the past 30 days, in smoking cigarettes daily, and in reporting having used hashish once or more often. And so these are some positive evidence that this approach worked. And they're continuing to do it, and they've tailored it to different individual cities, but it shows you the power of intervening and changing the environment and what it can do for not just substance use, but for other positive outcomes. So, the reality is that even if we were, and I'm hopeful that we will, invest a lot more money in primary prevention going forward with cannabis legalization, some people will continue to use cannabis, and so we need to have programs and strategies for them. So it's worth noting that there's almost no research on cannabis harm reduction for youth, and that's because it's been illegal, and so it's kind of been counterintuitive to try and do harm reduction with youth in schools around an illegal substance that they're not supposed to be using. But that being said, there is one demonstration project that I thought I would highlight. It's by Poulin and Nicholson. It was conducted in Nova Scotia. It's published in the International Journal of Drug Policy. And they had a really neat intervention where they basically developed a harm reduction program that was around cannabis and driving and other cannabis-related risk behaviors. And they changed the school community and tried to target peer norms, and they also imparted knowledge about how to stay safer if you are using cannabis, or if you're out with people who are using drugs. And they found not only was the intervention acceptable to parents in the school community, even though it was focused on a harm reduction message instead of an abstinence-only message, they also found that it reduced some rates of risk behaviors compared to the provincial averages in other schools. And so much more work needs to be done in this area, and I would say the evidence is far from conclusive, but it appears to be a promising approach in terms of doing reality-based education with young people. And so I'm a little over time, so I'll just wrap up, and sorry, Rebecca. Just to conclude, moving away from conventional approaches to preventing cannabis-related harm is consistent with a public health approach. Obviously, the devil's in the details, and we've heard a lot about the different options today, but criminalizing is not consistent with public health. We know it doesn't work, and it doesn't enable us the levers we have to reduce harm. New approaches require high-quality surveillance data to be effective, and that Icelandic model had annual surveys of students that they were able to monitor their progress, and that's really important. And reimagining universal prevention and development of harm reduction programs targeting older adolescents could have ancillary benefits for other risk behaviors and other substances. And in the context of a worsening opioid epidemic where more and more people are dying, and particularly younger people are harder hit, I think that is one of the most potential benefits that could come out of cannabis and overhauling primary prevention. Thank you.